Senate Committee on Health, Education, Labor, and Pensions will come to order, and I want to thank everyone for being here, and especially our panelists. It is no secret, I think, to most Americans that our current healthcare system is broken, it is dysfunctional, it is a cruel system. It is the only system in the industrialized world that does not guarantee health care to all people, and yet we end up spending twice as much per capita on health care as the people of other nations, and the result of all of that is that our life expectancy is significantly lower than many other countries, and our health care outcomes are often worse. But today, we are going to be talking about one of the most outrageous and cruelest aspects of this dysfunctional healthcare system, and that is that people who suffer and are trying to deal with terrible illnesses, cancer, heart disease, whatever, not only have to struggle to try to get well, struggle to get the treatment that they need, but then in the midst of all that, they are consumed with the reality that their family may go bankrupt because of the outrageous cost of healthcare. Truth is that in America today, the leading cause of personal bankruptcy. What is personal bankruptcy? People go to Las Vegas and blow their money gambling? Are they buying extravagant homes and fancy jewelry? No. The leading cause of personal bankruptcy in this country is the outrageously high prices that large hospitals, pharmaceutical companies, and insurance companies charge the American people for the crime of getting sick. Bankruptcy takes place because you get sick and need medical treatment. Let's be clear. The medical debt crisis our nation is experiencing is a uniquely American phenomenon. It does not exist in other countries around the world. We are the only major country on earth where an emergency visit to a hospital can cause patients to lose their homes and their life savings because of the high cost of the medical care. Imagine that, having a medical emergency, going to an emergency room, and then you lose your home as a result. How insane is that? I live 50 miles away from the Canadian border. And in Canada, if you spend a month in the hospital dealing with some terrible illness, you come out, the bill you get is zero. That's what you get. And that is true in most civilized, industrialized countries. In America today, over 66% of all personal bankruptcies in this country, some 530,000 per year, are related to unpaid medical bills. And after declaring bankruptcy, what happens? Your credit worthiness is destroyed. And if you are able to take out a loan, you will pay extremely high interest rates on anything you purchase as you spiral further and further into poverty and economic instability. And this is really stunning, and I really hope everybody hears this reality. This is the American healthcare system. The medical debt crisis in America has become so horrific that about 1 out of every 4 cancer patients in America either declared bankruptcy or lost their homes to eviction or foreclosure as a result of medical debt in 2022. Not enough that you're dealing with cancer. 1 out of 4 either declare bankruptcy or lose their homes. Now, how outrageous and disgraceful is that? Further, 42% of cancer patients in our country have been forced to deplete their entire life savings within 2 years of their diagnosis. And it's not just cancer patients who are struggling financially with medical debt and the high cost of health care. In 2018, 8 million Americans slipped out of the middle class and into poverty due to medical expenses. Again, punished financially for what crime? That you're diagnosed with cancer? That should not be happening. Nearly 1 out of every 4 Americans have skipped needed medical treatment because they can't afford it. Over 60% of Americans with medical debt have cut back on food, clothing, or other basic necessities. Now, some people may be thinking that medical debt is just a problem that impacts the uninsured, people without any insurance. That is not accurate. In America today, 61% of people who have health insurance have racked up medical debt over the past 5 years. In total, 100 million Americans 41% of our adult population owe $222 billion in medical debt. Let me just, a couple of days ago, my office, through our social media, we asked people around the country and in Vermont, tell us your experience with medical debt. Let me very briefly read a few of the stories that we got. A gentleman named Eric from Oregon wrote, quote, I received a traumatic brain injury and woke up from a coma with a hospital bill of over $500,000. How are you supposed to start a new life being $500,000 in debt after being in a coma for 3.5 months? That's a hell of a way to wake up. Melissa from Montana wrote, quote, I developed heart failure from an abnormal heart rhythm in my 30s. I had no insurance. My family of 5 went bankrupt and lost their home. I'm in my 50s with a career in speech pathology, and I still can't afford health insurance, end quote. Andrea from Nevada wrote, quote, my mother got colon cancer. She did not have adequate insurance. They wanted $3,000 up front before they would start her chemotherapy treatment. It would then cost another $3,000 a week for a minimum of 10 weeks. She never got a single chemotherapy treatment. End of quote. We can only imagine what happened. So that's the bottom line. Are we a nation which says that if you come down with some terrible illness, you run the risk of destroying the financial stability of your family? Is that really where we are as a nation? I think not. And today we're going to begin to hear, and in my view, needless to say, we need to transform our entire healthcare system, move to Medicare for all, but that's not what we're discussing today. What we're at least looking at today is how short-term we can protect the many, many, many millions of people who are struggling financially because they committed the crime of getting sick. Senator Cassidy, the floor is yours.
Thank you, Chair Sanders, and hey, thank you all for joining us today. Incredibly important topic, really appreciate. I'm a physician. I worked in a hospital for the uninsured for 20 or 30 years. I've been at the bedside where I've had to tell someone they've got a terrible disease in which they may have hope, but nonetheless it's going to be tough, or maybe in some cases the diagnosis is more likely than not fatal. The last thing you want them to be concerned about is medical debt. That is a burden which they need not have. So we've got to address medical debt. But in medicine, we have a saying, don't just do something, think. We have to think about what is causing this. As you think about it, the medical debt is a symptom of a larger problem, the high cost of health care. What is driving that? If we address that, then we will kind of, along the way, address the issue of medical debt. Not entirely, substantially. Right now, Americans pay more for health insurance than ever before. On the Affordable Care Act exchanges, the average monthly unsubsidized insurance premium on a silver tier plan is $483 for a 40-year-old. For a family of 4, the average unsubsidized is $1,600 per month. And the average deductible is $5,000. So this is the amount that the patient is paying before they benefit from the plan. So this kind of coverage is oftentimes unaffordable, and this is what can lead to medical debt. We have to examine where patients are taking on this debt. Data shows that hospitals are responsible for more than half of medical debt. Well, that's important. Congress has long provided additional resources and support to hospitals to help cover the cost of a patient who may otherwise be unable to pay. Many federal grant programs are available to hospitals in financial distress to ensure that they continue they should be able to continue to be helpful to those who are unable to pay. One example of this is the 340B program, where hospitals are able to bill full rate for a drug which they acquire at a sharply discounted amount. And the idea is that they would use that delta, that profit, if you will, to help the patient. But there's other examples too. The disproportionate share program, or sometimes the upper payment limit program, as well as a nonprofit and tax-exempt status for many hospitals. There are a lot of resources out there for that 50% of the medical debt, which is contributing to the problems that the chair just spoke to. Speaking specifically about 340B, hospitals participating in 340B get substantial discounts on prescription and oncology drugs, but it is unclear if these discounts are actually being passed to patients. Since last year, I've led an investigation in how different healthcare entities are using this 340B revenue. The chair has declined to participate, but it's an important topic to consider if we're going to address both a root cause of medical debt and two, why are the things that we're putting out there that may potentially address this not addressing it? If we just put in one more program, which is poorly implemented, we're going to be back in this hearing 5 years from now. We've got to see how the ones we've already done are actually working. Don't just do something, think. So I'll also point out that it's been proposed that we just cancel all medical debt. My colleagues on the other side of the aisle suggested that. But to be clear, a one-time cancellation of medical debt is not a solution. It is a Band-Aid approach for a one-time problem that's going to come back. Don't just do something, think. It also shifts the debt upon taxpayers and upon those who, we think it's free. It's not free. If people haven't noticed, we've got this incredible debt and deficit in our country. And that's going to weigh upon our children and our grandchildren, upon these young interns who are here. What about our obligation to them? Don't just do something, think. Well, may hear today about Medicare for All, it's been mentioned, but I'll also say that a healthcare system in which you think it's free because the taxpayer is footing the bill, you've never seen how expensive something can be until you perceive that it is free. This committee has a long history of engaging in real bipartisan efforts to ensure that our healthcare system works better for patients. Just last year, the committee passed the PBM Reform Act to address malaligned incentives affecting PBMs and the price patients pay for their prescriptions. We need that signed into law. That would be a way to begin to lower the costs for patients. There's other examples too. I look forward to exploring them. I thank you all for being here. You represent a spectrum, but this country is a spectrum. And so ideally, we're going to learn from you the kind of width and breadth and depth of that which we can do as a government to help reduce medical debt for all Americans. Thank you. I yield.
Thank you, Senator Cassidy. Just one word. Please, as we proceed in this discussion, remember, we as a nation are spending twice as much per capita on healthcare as the people of other nations. Our first witness is Dr. Abdul El Sayed from Wayne County, Michigan. Dr. El Sayed is a physician, epidemiologist, and director of Wayne County's Department of Health, Human and Veterans Services. Wayne County is seeking to cancel up to $700 million in medical debt for its residents. Dr. El Sayed, you may proceed with your testimony, and we thank you for being here.
Thank you so much. Chairman Sanders, Ranking Member Cassidy, and members of the committee, thank you for the opportunity to testify before you today. My name is Dr. Abdul El Sayed. I trained as a physician and epidemiologist. I serve Wayne County, Michigan as its health officer and director of the Department of Health, Human and Veterans Services. Wayne County is home to the city of Detroit, 42 surrounding communities. It's Michigan's largest, most diverse county with 1.8 million residents. In our county, we've been the epicenter of one of America's most pernicious epidemics, and that's the scourge of medical debt. I'm going to talk more about what we're doing about it. But to set some context, I want to share a personal experience. About a year ago, I began to feel a heaviness under my right inguinal line when lifting weights. As a physician, I knew exactly what was going on. Nearly 30% of men will develop an inguinal hernia at some point in their lives. Hernias aren't painful, they don't hurt, but they can grow with time under pressure. And treating an inguinal hernia requires a surgery that attaches a mesh over the defect in the abdominal wall. Inguinal hernias present a peculiar conundrum. Treatment is a medical necessity because of the risk of intestinal incarceration, which is a medical emergency that can be deadly. But incarceration only really happens 10 to 15% of the time, which means that most people will find their hernia to be an annoyance, but not much more. So to treat or not to treat, and that should be a medical question, a decision made with one's doctors. For me, it should have been an easy decision. I was a physically active 39-year-old with growing bilateral hernias. So why tempt fate? Well, because hernia repair is really expensive. That's even with insurance. See, I got my surgery on April 12th, and our family's in-network deductible is $3,200. Our maximum annual out-of-pocket is $4,600. And as of the end of June, so that's just 6 months into 2024, and only 3 months since my surgery, we've already paid them in full. all because I got a medically necessary surgery intended to allay the discomfort of having my intestines bulge every time I so much as speak loudly like this, and to prevent a medical emergency that could kill me. And I want to be clear, I'm one of the lucky ones. Had I not been insured, had I not had the means to pay my out-of-pocket costs, or had I only learned about my hernia after I presented to an emergency room with an incarceration, I might have wound up being one of the millions of people in this country with medical debt. And these impossible choices too many Americans are forced into are why we hold so much debt in this country. The consequences are staggering. Medical debt is the leading cause of bankruptcy, as Senator Sanders mentioned. Together, we owe at least $220 billion in total medical debt. To put that in perspective, that's more than the GDP of half the states in this country. Medical debt is a hazard. It leads to healthcare discrimination and delayed care. And beyond health, nearly 2 in 3 adults experiencing it report cutting back on food, clothing, and other basic household needs to pay down their debt. It's a uniquely American problem. Why? High and growing healthcare costs and porous health insurance coverage, all stemming from the fact that we're the only high-income country in the world without universal healthcare coverage. Healthcare costs have gone up 25% in just 5 years, and rather than act on behalf of consumers and push back on rising prices, insurance has just passed the costs onto people through what's called cost sharing, in the form of deductibles and co-pays and co-insurance. Over the past decade, premiums, what you pay just to have insurance, have grown faster than wages and inflation, and deductibles have more than doubled. So let's be clear. What causes medical debt in America? Providers are raising costs, and the insurance industry is passing them back on to everyday people. And that's hit us hard in Wayne County. We ranked number 8 nationally for counties affected by medical debt. In response, County Executive Warren Evans made alleviating medical debt and expanding healthcare access a primary goal for our county. In March of 2024, we announced a program in partnership with Undo Medical Debt to relieve medical debt for qualifying residents, braiding funding that originated as ARPA with local funding to support indigent healthcare. The program leverages a unique fact, that the real value of medical debt actually falls with time after non-payment. And UMD works with local hospitals and healthcare providers to purchase their debt for its real value rather than the nominal cost. That allows them to buy medical debt for pennies on the dollar and is allowing Wayne County to purchase upwards of $700 million of debt for just $7 million. But we need debt relief nationally, and we also need to work toward an America where people don't accrue medical debt in the first place. Toward that end, the single best solution to address both rising healthcare costs and porous healthcare coverage is to pursue single-payer health reform, also known as Medicare for All. Medicare for All offers a single plan for everyone without out-of-pocket costs, and it's durable to life's twists and turns. With the power to negotiate down our costs and eliminate the exorbitant healthcare overhead in this country, it's also critical to addressing our rising national healthcare costs. I began today by sharing my experience choosing between medically necessary care and nearly $5,000 of paying out-of-pocket costs, or the risk of a ticking time bomb in my own body. Millions of Americans make similar choices every single year. I was one of the lucky ones. Millions of others are not. That's why we're working to erase medical debt in Wayne County, and you have the opportunity to do so for all Americans, and maybe more importantly, to make sure millions never fall into the same impossible choices in the future. Thank you.
Dr. El-Sayed, thank you very much. Our next witness is Dr. Luke Messac from Boston. Dr. Messac is an ER doctor and attending physician at Brigham and Women's Hospital and an instructor of emergency medicine at Harvard Medical School. His research focuses on the history of medicine, medical debt, and patient access to care. Dr. Messac, thanks very much for being with us.
Thank you, Chairman Sanders, Ranking Member Cassidy, and distinguished members of the committee. Thank you for the opportunity to appear before you. My name is Luke Messac, and I am an emergency physician and historian at I'm an emergency physician and historian at Brigham and Women's Hospital and Harvard Medical School. The views expressed here are my own. The toll taken by medical debt and by the fear of it are clear every day in the ER. My patients worry aloud that if they follow my advice to stay overnight for testing to see if their chest pain is a heart attack or if their dizziness is a stroke, they will face even more debts they cannot pay. Some fear debt so much that they show up too late. I will never forget the woman who came to the ER one evening with a fungating cancerous mass. She told me she had noticed it 6 months before, but she did not go to her doctor. When I asked why, she said she feared the bills she would leave her family. By the time she came to us, what had been a treatable cancer was now widely metastatic, and all she wanted was relief from her unremitting pain. When my patients shared concerns about medical bills, I used to try to reassure them. But as I came to learn, patients are right to fear this debt. When I visited my county courthouse in Rhode Island during residency training, I found that my own hospital was suing patients, including single working mothers and the disabled. Across the country, hospitals and debt collectors report low-income patients' debts to credit bureaus, garnish patients' wages, seize their bank accounts, and even seek warrants for their arrest if they miss court hearings. When I first learned what was being done to my patients, I was overcome with surprise, then anger, and then with shame. Patients come to us on the worst days of their lives. We use our years of training to diagnose and treat potentially fatal conditions. I chose emergency medicine as a specialty because it was, to me, the most direct way to treat patients in danger and distress, to bring people on the verge of death back to health and to the people they love. This work involves a sacred promise to be there for anyone, at any time, to treat anything. We want to be worthy of our patients' trust, but we cannot do that if we are part of a machine that uses lawyers and judges and collection agencies to squeeze the sick and the vulnerable for bills they cannot pay. We know that patients in debt avoid necessary medical care. Americans with medical debt are 3 times more likely to forego care than those who have none. Patients in financial distress after a cancer diagnosis are less likely to follow treatment recommendations and have lower survival rates. While some commentators continue to insist on the risks of moral hazard and the virtues of copays and deductibles, we have decades of evidence, including a study published just this year in the prestigious Quarterly Journal of Economics, that the more Americans are made to pay out of pocket for medical care, the sooner they will die. While we work every day to save patients, medical bills and medical debt are killing them. There are some simple and affordable solutions to this problem. In exchange for their tax exemptions and in line with their historical origins in almshouses, community associations, and religious institutions, nonprofit hospitals are required to publicize their policies on financial assistance. This aid is meant to prevent low-income patients from incurring debt in the first place. But applying for assistance currently involves needless paperwork. To fix this, the IRS can use existing authority to allow hospitals to verify patient income and to tell patients at the point of care that there will be no bill. We can also cancel existing debt in a way that helps struggling hospitals while delivering the most possible benefit for Americans' health and financial outcomes. Recent research suggests that debt cancellation works best if done before debt collectors start pursuing patients with threatening letters and lawsuits. To finally end medical debt, we will need universal coverage without copays or deductibles. This can take many forms, none better than Medicare for All, which has been endorsed by the American Public Health Association, the American College of Physicians, and National Nurses United. Physicians, nurses, and other healthcare workers have a calling, one that my mentor, the late Dr. Paul Farmer, called expert mercy. It combines the best of scientific inquiry and the tradition common to many faiths of caring for the sick. By ridding us of medical debt, you can help us live up to this mission. Thank you.
Dr. Messac, thank you very much. Our next witness is Allison Ward from Chicago. Ms. Ward is a neonatal nurse practitioner at the University of Chicago Medical Center. She has personal experience with the difficulties of medical debt and ongoing medical costs of taking care of her family. Ms. Ward, thanks very much for being with us.
Good morning. I would like to thank Chairman Sanders, Ranking Member Cassidy, and all members of the Senate Health, Education, Labor, and Pensions Committee for holding this important hearing and for inviting me to speak today. My name is Allison Ward, and together with my husband, we are the parents to twin boys. I am also a neonatal nurse practitioner. I would like to share my experience as a parent of children who spent over 6 months collectively in the neonatal intensive care unit and the impact that medical debt has had on our family. Our life as parents started abruptly when Milo and Theo were born at 30 weeks gestation, 10 weeks prior to their expected due date, weighing just 3 pounds each. We had health insurance coverage through my employer, but even with this coverage, we were still responsible for a significant portion of the cost of medical care. The reality of the situation and the related anxiety began when we received a bill that totaled upwards of $25,000 within the baby's first month of life. We were told on multiple occasions that it was important to concentrate on the health of the babies and set aside our financial worries. During this time, we were also anxious, as we knew it was either the hospital calling to share news of an unexpected setback with the boys, or it was a debt collector. This was a particularly scary time for us as new parents. I returned to work earlier than my anticipated 12 weeks of unpaid maternity leave to begin receiving a regular salary again and contribute to the payment of medical bills. My breast milk supply dwindled, and I missed the opportunity to be present at times when my sons really needed me. My husband was completing a master's program and providing care for one baby at home while the other baby remained hospitalized. I would stay after my shift at work to visit my baby in the hospital, to hold him, change his diaper, and breastfeed or give a bottle, and then rush home so my husband could come to the hospital to see him for the night. We were so thankful that both of our sons survived a very critical situation and that things were improving for our still hospitalized baby, but struggling, as each day requiring medical care meant more debt. Ultimately, our family portion of the boys' care exceeded $80,000. We put some charges on credit cards and attempted to set up payment plans for many of the remaining expenses. The impact of these costs led us to the brink of financial exhaustion on several occasions. We spent a great deal of time thinking about which set of parents we would live with if the cost of care outweighed our ability to pay for housing. We were also very unsure of how we would move forward with other life plans, like how to rebuild our savings or if we would ever qualify for a mortgage. While the majority of the medical debt originated from the boys' first year of life, there has been an ongoing need for procedures and therapies to maintain their quality of life. Both boys were diagnosed with mild cerebral palsy, which required extensive physical therapy. I often worked a second job, working up to 60-plus hours per week in order to pay to meet these necessary treatments. During some of our most dire economic times, we would meet with the children's therapist and ration out the most necessary care at that particular moment and reassess again the following month, knowing what a detriment missing these sessions could be for their overall health and well-being. Our situation parallels the experiences of many families that I have cared for as a nurse practitioner in the NICU. Families often share devastating levels of stress as they attempt to balance staying with their baby during hospitalization or leave the baby to return to some level of employment. When parents are not able to be present with their children in the hospital, it often leads to higher levels of postpartum depression, decreased availability of breast milk, and decreased parental-infant bonding, all of which can negatively impact the overall health and well-being of a family. After hospital discharge, many infants require equipment such as oxygen, feeding tubes, and feeding pumps. For children born prematurely, healthcare costs after discharge can range between $200 and $3,000 per month. The cost of these items, along with the necessary therapies, are often not covered by insurance, leaving families to figure out how to afford expenses that are essential to their child's health and well-being. Parents are often asked to make impossible decisions. Do they access the level of care that doctors indicate is needed to likely improve their child's health? Or is care only accessed when it is absolutely and emergently needed? I will feel forever grateful of the care that our children received. I am happy to report that our boys are inquisitive, smart kids who like to ride bikes and rock climb. They are blissfully unaware of many of the complications of their prematurity. My hope is that other families are able to experience life without having to choose if a needed medical procedure or can be delayed until a previous bill is paid in full. We should allow for families to follow the advice of their doctors and healthcare providers and not be beholden to a payment structure. I look forward to a time in which my patients and their families do not have to choose a less effective treatment or medication because of the cost. Medical debt cancellation would have reduced the amount of time that I was away from my children in their first few months of life. It would also have allowed for a longer duration of breastfeeding, which could have ultimately improved our son's medical outcomes. Cancellation could have also offered our children to fully receive the services that they needed as ordered by their physicians and medical team. We would not have had to ration care and wonder if their health was going to be impaired by our lack of ability to pay. Thank you.
Ms. Ward, thank you very, very much. Our next witness is Dr. Fumiko Chino from New York. Dr. Chino is a cancer researcher, assistant attending physician in radiation oncology, and leads the Affordability Working Group at Memorial Sloan Kettering Cancer Center. Dr. Chino, thanks very much for being with us.
Thank you so much for the opportunity to speak with you today. My name is Fumiko Chino, and I'm an oncologist at Memorial Sloan Kettering Cancer Center. Every day, I use advanced technologies to treat and cure patients with cancer, and I also do research on how to make healthcare more affordable. I come today to speak to you about the harms of medical debt as an expert in the field, but also as someone who has personal experience with the financial devastation on patients and families of a cancer diagnosis. My testimony today represents my personal position and not necessarily that of my employer. On the day after his 27th birthday, my husband Andrew started having pain and throwing up. When he was finally diagnosed, we learned that he had a fast-growing tumor that had spread throughout his body. We knew that we would have to make some sacrifices in order to afford his care. Nobody thinks that cancer treatment is free. But we had no idea about the financial burden that cancer would force on us. Our subsequent struggle through the healthcare system highlighted dangerous holes in its coverage, and it left me realizing that many Americans are one diagnosis away from catastrophe. Even with health insurance, the high costs of care are leaving some American families adrift in debt. Within 6 months of Andrew's diagnosis, we had maxed out his prescription benefit and had to start paying out-of-pocket thousands of dollars for his medications. Another couple of months later, we met a lifetime cap. His health insurance stopped paying for his treatment, and we were left on the hook to pay to keep him alive. I cashed out my 401k, we postponed our plans to start a family, and we borrowed money. We even considered moving to Canada. It was in the gray winter that Andrew died, leaving me in an empty apartment with an empty future and a stack of bills. Even though Andrew was gone, the debt remained. I was hounded by debt collectors. One even called me when I was at his funeral. The debt was like a black cloud. It followed me and cast a shadow over my entire future. It wasn't until years later that I discovered that despite the threatening phone calls and letters, I wasn't legally responsible for Andrew's medical debt. Even today, I get calls from collectors trying to cash in on his sickness. Our experience made clear the gaps in the US healthcare machine, a system seemingly designed to put profits over people. After Andrew's death, I decided to go to medical school to try to change the system from within. The US has a growing contingent of people who cannot afford their necessary health care. Many consider selling their homes or declaring bankruptcy, forced to literally choose between their money and their lives. There are more people who are worried about the financial costs of a cancer diagnosis than from dying of cancer. And 40% of Americans have depleted their life savings within 2 years of a cancer diagnosis. Our own research shows that costs drive 1 in 4 to place their cancer survival at risk by skipping appointments, scans, medications, or avoiding treatment altogether. Debt relief is needed now. Senator Sanders has introduced legislation aimed at eliminating medical debt for working Americans. This is particularly important for people with cancer who are uniquely at risk. We are curing more cancers than ever, but those higher costs can haunt patients and families for years. Over half of surveyed patients with cancer report medical debt related to their treatment, and more than 2/3 of them have carried that debt for over a year. Prior research has shown that medical debt has associated with worse health and higher mortality. Improving public health is just good politics. Investing in American health pays out in better long-term outcomes. Medicare for All promises to disengage the pursuit of profits from the delivery of health care. I ask you to work together to improve access and affordability, to evolve health insurance, and to enhance value in health care. I have worked hard to reinvent myself with purpose. Today, I am a physician and a researcher on a mission to improve cancer care in America, to take the lessons that I learned from blood, sweat, and tears and turn it into a better future for the next patient that walks through my door. Ultimately, the fear that I share with so many of my patients is that we will slip even further into the abyss. Without action, we need to chart a path forward where a new diagnosis does not automatically mean that you will face financial ruin, and so that no one else needs to make the difficult decision of life over life savings. Because at the end of the day, I can tell you that you can lose both.
Dr. Chino, thank you very much. Senator Cassidy, you want to introduce your panelists?
Yes, it's my pleasure to introduce Dr. G. Bai. Dr. Bai serves as a professor of accounting at the Johns Hopkins Carey Business School and as a professor of health policy and management at the Johns Hopkins School of Public Health. She's an expert in healthcare accounting, finance policy, research focusing on healthcare pricing, affordability, and the root causes contributing to medical debt, all central to today's discussion. Thank you, Dr. Bai. I'll note whenever I look in the medical literature, Dr. Bai publishes on a whole variety of topics. It's incredibly impressive, so thank you for sharing your expertise with us.
Thank you so much, Senator Cassidy. Thank you. So, Chairman Sanders, Ranking Member Cassidy, and the members of the committee, thank you so much for giving me the great honor to be here. As Senator Cassidy said, I'm a professor at Johns Hopkins, and I'm a CPA, Certified Public Accountant. My views here today do not represent those of Johns Hopkins University or its affiliations. First of all, we do not have a medical debt crisis. We have a medical debt problem. In February this year, the Peterson Center on Healthcare estimated, and a Kaiser Family Foundation estimated, 8% of US adults have medical debt. And among the medical debts, 14% are above $10,000. Medical debt is a symptom reflecting underlying disease. If we do not address underlying disease, we can never fix medical debt. And what is the underlying disease? The high healthcare price. So why is the healthcare price so high in the US? Primarily because our government policies have continuously tilted the playing field in favor of large players and detach patients further and further away from their healthcare dollars. So let's take 340B program, for example. So Congress designed the 340B program as a buy low, sell low program. So for the nonprofit hospitals and the government hospitals to buy drugs at a discounted price and sell them to low-income patients at a low price. But guess what happened? Now these hospitals ended up buying low and selling high. So recent studies published in JAMA Internal Medicine and New England Journal of Medicine found that the 340B hospitals, the set commercial price can be as high as 3 to 8 times of the list price of the drugs. And their markups are higher than the markups of non-340B hospitals and the physician practices. So basically, Congress has channeled the money to the 340B programs, 340B hospitals, and invites them to buy up physician practices and non-340B hospitals because they do not enjoy the 340B benefit. Congress also bans physicians from establishing hospitals and pays them much less than what hospitals get. That's why we do not have much independent physician practice. So basically, health system got all the government-granted advantage. They swallow physician practices, gain market power, and then raise price. That's why we end up with medical debt. Then should we just cancel medical debt? Now imagine grocery stores allow consumers to take on debt and Congress cancels it. Then we'll see more and more grocery debt. And then we'll see the quality and the variety drop. Why? Because the government pays, not the consumer pays. There's no reason anyone should care about what the consumers want and what the consumers like. This is exactly what cancellation of medical bill will lead us to, harming all patients, all Americans eventually. So how should we fix medical debt? Very simple. We should correct policy failures that have inflated medical price in the first place. Number one, level the playing ground, right? As Dr. Cassidy already mentioned. So let's fix the 340B program. Let's fix the site-based payment program. Let physicians freely compete and innovate. Number two, let patients control their healthcare dollars so they can personally and directly benefit from better health and lower healthcare price. Number 3, let's codify transparency. So as the Braun and the Senator bill already has listed, there are many provisions we can implement so that we can ensure the integrity of the billing and promote competition. What if the billing amount on the medical bills are wrong, right? So we need the Braun and the Senator bills to be implemented. This is the only pathway for us to fundamentally fix medical debt and benefit all Americans. Thank you very much.
Thank you very much, Dr. Bai.
It's next my privilege to represent Dr. Ben Ippolito. Dr. Ippolito is a senior fellow in economic policy at the American Enterprise Institute, research focusing on a variety of topics within health economics and the role of healthcare costs in the personal finances of Americans. He's an expert in medical debt and will be able to speak to the broader consequences of medical debt relief. Dr. Ippolito, thank you for being here.
Well, thanks very much, Ranking Member Cassidy, Chairman Sanders, and members of the committee. Like you said, I'm Benedict Ippolito. I'm an economist at AEI, and much of my work focuses on healthcare costs broadly, but how that affects the personal finances of Americans. It's been alluded to before, but medical debt attracts justifiable attention. It's not just that healthcare is unpredictable, but medical debt reflects these other features of healthcare markets that we don't like. The costs are high, the billing is complicated, the billing can be inaccurate, many other things. That said, the landscape of medical debt is also rapidly changing. Recent policy changes have reduced the influence of these debts on credit reports already, and existing proposals would seek to reduce their role in personal finances further still. And so with that in mind, I do want to make just 2 points. First, I really do not want to be pessimistic, but policymakers should have realistic expectations for how much these changes will improve broader measures of consumer finances, since of course that is one of the goals here. At this point, we have a very large body of research, including analysis of real-world settings, Medicare, Medicaid, the ACA, and randomized controlled trials of medical debt forgiveness. And those have shown us that large reductions in medical debts, perhaps surprisingly, generally do not lead to large improvements in other financial outcomes. The effects on credit scores, delinquencies, credit utilization, bankruptcy, other financial measures are often zero on average. Not in all cases, but on average. In part, that likely reflects the fact that most medical debts ultimately do not get repaid. That means if you prevent a medical debt or you forgive a medical debt, you may not be freeing up the money in the same way that you might have otherwise thought. It also may reflect the fact that medical debt, while common, may still be a modest portion of the overall liabilities facing a household. There is, depending on how you measure it, $100, $200 billion in medical debt. Household debts total over $17 trillion. Even without mortgages, you're close to $5 trillion. It may just be that those factors overwhelm the effects of medical debt. Regardless, I do think it is important to set appropriate expectations for how these policies will affect consumers, and I do worry that some predictions can be a bit misleading. Second, there are trade-offs that I do think policymakers should be aware of, and I'll highlight one that I think is relevant for the goals that I think many people have in mind. Eliminating medical debts from credit profiles or forgiving debt reduces the cost or the consequences of unpaid bills to consumers. That is, of course, the point of doing that. Mechanically, though, that also reduces the incentives for consumers to pay those bills. Indeed, a recent randomized controlled trial showed that medical debt forgiveness resulted in a modest reduction in the payment of existing medical bills. And while it is completely understandable for people to respond to those incentives, we should also expect others to respond to incentives like providers. So for example, I would fully expect providers to increasingly seek more payment up front. Indeed, a recent Wall Street Journal article noted the portion of patient cost sharing paid in advance of hospital care has risen to nearly 25% in recent years. I would not be surprised to see that number increase. And while it's not inherently bad to pay more of the bill up front, it has some transparency and competition benefits that presents a potential barrier. If you're somebody who cannot otherwise pay a bill, suddenly that presents a barrier to getting care in the first place relative to a world where you pay the bill after. We've also seen the use of medical credit cards and similar financial tools rise in recent years. So these are products that are typically offered in provider offices, and they allow the provider to secure payment for the services immediately and have the patient then reimburse the card issuer rather than the provider going after them for reimbursement. The CFPB noted that just one of these cards grew from 4.4 million cardholders to nearly 12 million over the last 10 years, and I'll reemphasize, that is just one medical credit card. Again, this is consistent with the point that providers are concerned about securing payment from patients, and I would anticipate that recent policies are going to amplify those trends. And given the goals of these policies, which include access to healthcare, I think that's quite relevant for policymakers to keep in mind. I would personally argue for better understanding how quite large recent changes have affected the behavior of providers and other actors, including lenders and others, before going further with respect to medical debts. But at a minimum, I hope you at least consider these trade-offs as you approach this issue. So thank you very much for having me, and I look forward to questions.
Thank you very much. Let me begin the round of questioning by mentioning that last week the governor of Illinois signed legislation into law to cancel up to $1 billion in medical debt with an investment of just $10 million in state funding. That sounds like a pretty good deal. We're talking about 1 cent on the dollar to cancel debt. Dr. El-Sayed, is that similar to what you're doing in Michigan? Why is that an effective way to go forward to take the burden of medical debt off of the backs of vulnerable people?
Yeah, thank you for the question. So the ratio of 1 cent on the dollar is exactly what we're pursuing in Wayne County. And it demonstrates the fact that though prices have gotten higher, those nominal prices are somewhat arbitrary. And the reality is that after non-payment of a medical debt, the value of that debt falls precipitously. And so we have a situation where I would argue that it's actually exactly the inverse of what my esteemed colleague, Dr. Ippolito, shared, which is that we have a situation right now where hospitals and providers, in effect, will create a certain number and say that's the price of the care. And people can't afford it, but they bank on the fact that a lot of people, because of the kind of beggaring that they get, will try and do so anyway.
How many people do you think you can help by removing their debt for how much money in Wayne County?
We estimate about 300,000.
For how much?
For about $7 million.
That sounds like a pretty good deal.
Yeah.
Dr. Messac, in America, 1 out of every 4 cancer patients either declared bankruptcy or lost their homes to eviction or foreclosure as a result of medical debt. Is there any other country in the world where that takes place?
No, not in the rich world. Countries as rich or close to as rich as the United States do not see this level of catastrophic health expenditure, not even close. We outpace the nearest OECD country by more than 2 times. So you're right that that's not something we see.
All right. And if I am diagnosed with a terrible disease, I worry about that a whole lot. My family worries about that. What impact on my health and my well-being does the worry about financial ruin mean to me?
Thank you, Senator. As Dr. Chino said, and as I mentioned in my testimony, there are so many consequences to worrying about health, and we know that patients who are in financial distress after a diagnosis, who are facing these medical debts, do not adhere to treatment recommendations. They're more likely to die, and this has been proven time and time again from the RAND study in the 70s and to the QJE study just this year. So it's a tremendous health consequence.
Ms. Wood and Dr. Chino, you both have dealt with serious, in one case, fatal illness in the family. What role were bill collectors playing during this process when you were worried about your kids and you were worried about your husband, Dr. Chino? Ms. Wood?
I think it's just the ever constant threat of someone calling to inquire for something that we were not able to pay.
Did that happen often?
I would say multiple times a day,
Multiple times a day?
Yeah, I would say oftentimes we were in the NICU visiting our children, and we would get calls from debt collectors asking for payment before the boys were ever discharged from the hospital. It caused a tremendous amount of stress on our family to the point that we debated not answering our phone many times if we were not with the boys because we were worried if it was the hospital or a debt collector calling. But we had to answer because, of course, it was the hospital.
So your kid's in the hospital, and you're getting multiple calls a day?
Correct.
From bill collectors?
We had 2 children, so double the calls. Yeah.
Dr. Chino, do you want to elaborate on that, or?
I just want to say how common this is and how heartbreaking it is that I know from my personal experience, but also that our patients are experiencing on a day-to-day basis, how excruciating these calls are, how harassing and threatening the messages are. I have patients
Elaborate on that a little bit. Threatening, what does that mean? You're dealing with somebody who is very, very ill, right? That's your main concern. What does that mean, threatening? from,
So, saying this is going to affect your credit, your ability to do anything in the future, we're going to take your home, we're going to take your car, where your future is over. Basically, I have found that debt collectors will play every dirty trick that they can to try to get you to give them some money. And it's just one extra layer of stress that when you're dealing with, for me, my husband was in the ICU for a month. It's intolerable.
to say the least. I mean, so what we're talking about is a wife worried about a husband in the ICU, or a mother worried about her kids struggling for their lives, having to field off calls from debt collectors. I mean, if that's not obscene, I don't know what is obscene. Senator Cassidy?
Yes. Ms. Ward, just out of curiosity, which hospital were your children treated at?
They've been treated in several. We were living in Dallas when the children were born, and then
So
we moved
the
to
NICU,
Chicago.
the NICU bill sounds like it was the most. Which hospital was the NICU in?
They were both at Baylor in Dallas, and then also at Children's Medical Center.
Sounds good. Dr. Messac, I assume the patient you described was treated at Brigham. Brigham's a nonprofit. They get disproportionate share, and it's a 340B hospital. All three are mechanisms by which it's supposed to help those who cannot pay their bills be alleviated from the burden. Do you know if Brigham ever reached out to those patients to help decrease their cost?
I should be clear, the patient I was talking about was at Rhode Island, where I did my residency training, so not in the Brigham system.
So Rhode Island, if it's an academic center, typically those are nonprofit. So that would again have 340B and a tax-exempt status. Did that hospital, and by the way, did that hospital, as far as you know, have a program? Or does Brigham? Let me ask about Brigham. Yeah. Do they have a program where if somebody comes in uninsured or poorly insured or with a high deductible to help offset the cost of that bill?
Yes, Mass General Brigham does have that policy. If up to 150% of the federal poverty level gets free care, up to 300% gets discounted care. All hospitals have to have.
So in a sense, that mechanism is then working. Dr. Chino, what a motivation for you, but what a terrible story for us about your husband. Sloan Kettering, again, it's a nonprofit, 340B, and disproportionate share, big disproportionate share state. Does Sloan Kettering have a program where they pass the 340B discount to the patient?
We are not a 340B program at Memorial Sloan Kettering.
I think you are. I looked it up, and I think I saw that you are.
Okay, that is news to me. I apologize. But I will say that our charity care program is actually quite robust.
But do they pass that, because you mentioned specifically the cost of drugs, do they pass that 340B discount to the patient?
We cover up to 500% of FPL for our charity care program, which is far more than we need to.
So is that for the uninsured, or would that include the people with a less generous insurance policy?
Up to 500% of FPL, yes.
So in that sense, the programs we have would address that portion of medical debt that would be at y'all's hospitals. That's important.
It's important, but you also have to realize that in New York City, even up to 500 FPL is not necessarily a livable wage. And I know that sounds insane. And when you think about a charity care program, for example, for my husband, he was underinsured, but he was also a college professor, so we did not meet any actual charity care program, and yet we still fell into massive debt related to his care.
Presumably, he would have been below 500% of FPL if he was...
He was not treated at Memorial Sloan Kettering.
Got it. In the hospital where he was treated, was that a 340B nonprofit?
I apologize, I do not know that, sir.
Okay. Do you know the name of the hospital?
He was treated at the University of Michigan initially.
Well, that would have been that would have been a 340B nonprofit. Dr. Bai, what we have here, at least in a couple cases, may be cases where a 340B nonprofit receiving disproportionate share dollars is not helping people with their medical expense. Is that a... And as it turns out, my staff just tells me that Baylor is also a 340B hospital nonprofit. So theoretically, we have hospitals which are supposed to be doing the right thing, and they're not doing the right thing. I guess it's not a market failure, but it's certainly a failure of a hospital to act in a way which would be consistent with that was intended by the policymaker. Any comment on that?
I believe that's exactly what the policymakers are trying to do. All these policies are in favor of large players, in my opinion, trying to build a coalition between the policymakers and the large players. So large players will just ignore what the patient needs and focus their effort on this influencing, capturing the regulatory process, legislative process, so that they got the best benefit, like more 340B, right? More site-based payments.
So they would act for more subsidy, but yet we have clear instances of that subsidy not being passed to the patient. Two things about your testimony. You said only 14% of people have a medical debt over 10K. In my statement, I mentioned that 50% of medical debt is related to hospital expense. So really, if these policies were actually implemented as intended, it would have a very positive impact. Dr. Ippolito, real quickly, I'm almost out of time. The No Surprises Act was supposed to eliminate surprise medical billing, and that was a major cause of medical debt. Has there been an analysis of the accrual of medical debt subsequent to the passage of the No Surprises Act?
Not that I'm aware of, but in theory, it should have helped.
Yeah, certainly the testimony we received at the time was a lot of medical debt was related to, I thought you were in network, turns out you weren't. And now No Surprises addresses that. Maybe that will be a policy that actually works. Mr. Chair, I may have a second round, but I'll yield right now.
Senator Kaine.
Thank you, Chair Sanders and Ranking Member Cassidy, and thanks for this wonderful testimony, extremely illuminating. I want to dig into two issues, medical debt and parents, and then medical debt related to dental costs. Ms. Ward, I'm going to start about medical debt with parents and ask you a question. High medical costs connected to pregnancy and childbirth are significant financial burdens for new moms and new parents. About half of births in the country are covered by private insurance, and 2022 analysis of claims data suggests that out-of-pocket costs for moms about $3,000 in addition to other costs that they incur. A recent survey of people experiencing healthcare debt found that parents generally are significantly more likely than non-parents to have healthcare debt because of their own or their children's condition. And the debt that's being reported for moms does not include other medical debt that they may have incurred for the children. This is just around childbirth. Medical care for infants can result in higher out-of-pocket costs and debt. And then the out-of-pocket costs connected with pregnancy and childbirth, particularly for new parents, come at a time when families are experiencing income loss. If you work with one of the 75% of the employers in the country that doesn't often offer paid parental leave, and also if you're looking for childcare in a nation that doesn't do a very good job of funding affordable childcare, having a child puts this kind of triple whammy effect on you. The ordeal that you and your family face sounds very harrowing, and you mentioned in your testimony that you were forced to ration care due to the financial impact of these outstanding hospital bills. Talk a little bit about how debt relief would have impacted the lives of you and your family as your children were young.
I think the main thing is that some of our care and some of our expenses were not just related to the hospital care. It came later for therapy and other kinds of treatment. So I think if we had had the opportunity to have debt relief, we would have pursued those therapies sooner, or we would have continued all the necessary treatment that was recommended for the children in a way that was consistent with what their treatment plan looked like.
So this, if we could figure out a path forward on debt relief, this would be a very pro-parent, pro-family, pro-child policy, and I think that's an important thing. And I want to ask Dr. El-Sayed a little bit about dental bills. Senator Baldwin and I in March led a letter from a group of colleagues to the administration about persistent coverage gaps in essential health benefits. We asked the administration to initiate rulemaking to institute a minimum standard of coverage and to establish a permanent structure to regularly review what essential health benefits are. Not long after receiving our letter, the administration issued a final rule expanding access to dental benefits by finalizing measures to allow states the option to add routine adult dental services as an essential health benefit. So for the first time, every state will be able to update their EHB benchmark plans to include routine, non-pediatric dental services, cleanings, diagnostic x-rays, restorative services like fillings and root canals. I hear from Virginians about this all the time, problems with lack of dental care, distance from dental service provision leading to huge health and other challenges. In your testimony, you mentioned that dental bills are one of the leading causes of medical debt, with almost half of adults reporting them as the cause of their medical debt. We've taken a small but important step in updating the EHB to allow for dental coverage. Can you speak to the impact that debt related to dental bills has on your patients?
Yeah, Senator, thank you for your leadership. I'll tell you, we do this weird thing in this country where we decapitate the head from the body. So if it's health care for your teeth or your ears or your eyes or even your mental health, we consider it something different and apart. But we all know what happens if you decapitate a body. Thank you for your leadership on this front, because I do hope that states will take up the mantle of including this as an essential health benefit. We often think about teeth as being something separate and apart because it feels like what happens in the mouth stays in the mouth, except for we all know also that the mouth is the gateway to the rest of the body. And we know that patients with significant dental caries or other oral pathology are far more likely to suffer long-term chronic health illness. You think about something like heart disease related. You think about something like lung disease, also related. And if
I can interrupt, sometimes a dental examination also reveals non-dental health conditions that are really important to catch early.
You're correct. You think about oral cancer, often diagnosed at a dentist. So, part of the responsibility here of thinking about debt is thinking about debt collectively, rather than making the mistake of, again, decapitating the head from the body. As we think about medical debt, given the statistic that you shared, nearly half of medical debt attributable to dental care, we need to be thinking about it collectively.
Thank you so much. Thanks, Mr. Chair.
Senator Budd?
Thank you, Chairman. The 340B program, it requires nonprofit hospitals to have a contract with state or local government to provide charity care for low-income patients. We know that. But the GAO, the Government Accountability Office, found that more oversight is needed to ensure that these contracts are valid and in compliance with the statute. Dr. Ippolito and the whole panel, thank you all for being here today. Doctor, what are the potential benefits of implementing a stronger verification process for contracts to ensure that 340B savings are allocated to those that are most in need?
I think this sort of builds on some earlier comments, but the sort of lowest hanging fruit, it seems to be in this area, is that we have existing policies that are meant to subsidize hospitals and meant to explicitly subsidize the care of those who cannot pay in full or at all. And so 340B is certainly one of those, and so it strikes me as entirely reasonable to set up some standards and enforce some contracts about what exactly are you doing with that money.
Are those fairly straightforward verification procedures?
My understanding is that there is almost no verification of what you do with 340B money at this point, and so anything that moves in that direction seems like a step in the right direction.
But it wouldn't be overly complicated to create a system of verification?
It doesn't seem terribly complicated, no.
It seems like one of the central problems, not just with that, but with the American healthcare system, is just that it's not consumer friendly. I faced that as a parent. But so you got some providers out there that are very creative, like the Surgery Center of Oklahoma. They've posted transparent prices. I saw this years ago traveling to India. I think it was Apollo system. If you want a knee replacement, there's the price. It was basically a menu. You know the infection rate, you know the statistics for the hospital. People traveled from all over the world there. That's been several years since I was there. But you see innovative menu-like pricing and consumer-friendly pricing in systems in Oklahoma. So they've also negotiated directly with employers, and they've reduced administrative overhead. And what we've seen is that it's led to more savings for patients and decreased opportunities for medical debt to accrue. So how can providers differentiate themselves in the market by offering more consumer-friendly arrangements and better upfront cost estimates for patients?
Yeah, I mean, I think this speaks to a broader point. Insurance works best when it is focused on these rarer, expensive conditions that are very hard for people to prepare for. It doesn't work so great if you're covering relatively routine or predictable or shoppable services. And so I think this question is sort of getting at this point of, well, can't we do this a little bit more efficiently if we skip all this administrative cost? And you allude to a point that comes up all the time when the CFPB writes on this, when people submit comments regarding medical debt. The complexity of billing and inaccuracy of billing is a major issue here. And so to the extent that these models move towards a simpler, more transparent billing model, that seems like a major step in the right direction.
I like the way you started with that. I think you pointed to the difference between the promise of health insurance and the promise of health care. Very different. What are some of the obstacles to more simple, consumer-friendly arrangements?
Well, right now, I mean, if you're an insurance plan, you have to cover all sorts of mandated things, and the federal government, through a variety of regulations, essentially dictates some essentially minimum coverage requirement. That's the federal and state governments have roles in that. And the more you do that, the more that you make it kind of challenging for anybody to deviate. It also, I will note, tends to preference the largest players. If you are a big player and you put handcuffs on anybody else from making a different product that somebody might be interested in, that tends to help you maintain your market share. So those are the things I would point to.
Any other ways that you can think of off the top of your head where government is the obstacle rather than the solution when it comes to healthcare providing?
You know, I think one of the big things that Dr. Bai brought up is the government often has well-intentioned policies that has unintended consequences that we are very, very slow to unwind. Things like Medicare policy that encourages consolidation and higher Medicare spending is a great example. 340B tends to push in that direction as well. So I think those are sort of first-order issues for me. Government policies that tend to push towards consolidation and higher costs that underpins all of the conversations we have about medical debt and related issues.
Thank you very much. Thank you all. Chairman, I yield back.
Thank you. Senator Smith.
Thank you, Chair Sanders, for holding this hearing, and thanks to all of you for being with us today. You know, I was just thinking about what you were saying, Dr. El Sayed, at the beginning about how what's causing medical debt is the high cost of care and then the poor insurance coverage, and constantly people are finding some new thing that they are supposed to pay for that they didn't know that they were supposed to pay for. And I mean, just to be clear, you know, my view of it is that healthcare should be a human right, and your opportunity to get the healthcare that you need shouldn't depend on who you are or where you live or how much money that you have. And I do agree that the solution should be universal healthcare. My question, so this is where I want to go with my questions, because I think that since that is not the world that we live in right now, I'm very interested in trying to get at, like, how much this damn stuff costs. And, you know, I just want to say I'm glad Senator Cassidy is here, because Senator Cassidy and others of us did really important work on getting at the surprise medical bill and people finding suddenly there's a surprise and what's, you know, they were a cost that they weren't expecting, and how that shouldn't be borne by patients in that transaction. I'm also really interested in a bit of what Senator Budd was getting at, which is, like, there is so little transparency for people who are seeking health care to know how much things cost. It's, of course, one thing if you find yourself in an emergency room with an urgent need and you don't really have any choice. But if you're trying to, say, for example, do a knee replacement or a hip replacement, it's almost impossible to figure out what the actual cost is, or like how much you would pay if you went to this place, you know, place A versus place B. Now, CMS in January of 2023, the Biden administration put out rules requiring hospitals to post upfront prices, but I mean, the compliance with that is very low. I'm very interested in the bill that Senator Braun and Senator Sanders have worked on, the Healthcare Price Transparency Act, which I think would help to get at some of this issue, requiring some easily understandable way for people to understand how much things are costing so that they can make educated decisions. I wonder if Dr. Messac or Dr. El Sayed, if you would be interested in just commenting on this and what you've seen in your practice about the challenges of knowing, you know, basically how to be a good selector when you're trying to figure out how much stuff costs.
Let me first speak from a policy level, and I'm going to answer this question in an interesting way. I love Costco. And one of the reasons I love Costco is because Costco has a policy where their markup is not going to be greater than 15% the cost of the actual good.
Right.
Part of the issue is that our costs are non-transparent, so they hit people in some really profound ways, and they hit them when they're hurt the most, literally insult to injury. But the other part of it is also what those costs are. And we don't really have a way, to your point, about assessing why the Advil you got in the hospital was so much more expensive than the Advil you got at Costco. And if we're serious about addressing this issue, we really do need to be thinking about the ways that prices grow. The second thing I want to say about this is just that it's not only that we have the highest prices and the fastest growing prices in the world, It's that we have the highest overhead for healthcare in the world. And a lot of that is about billing complexity. It's about all of the billers that you have to hire on either side of a financial transaction that allow that transaction to happen because we have such multiplicity in our system of both providers and payers. The provider side is great. You get to pick which provider you go to. But when it comes to that many payers, each of them with an army of billers, it creates a real problem.
Yep, that's right. Dr. Messac, and I just want to say, I mean, I have talked to hospitals who tell me the extensive amount of money that they have to invest in getting the insurance companies to actually pay for the stuff that they're supposed to be covering. And that adds cost to the whole system as well. But Dr. Messac.
Yeah, thank you, Senator. I think price transparency is a good step. Taken by itself, it would do some good. I know a lot of my patients also often ask how much things will cost, and I can't answer their question because I don't know myself, and it's a big source of concern. I do worry, being in the emergency room, like you said, that patients come to me delirious, sometimes unconscious, and they have no choice in where they end up. And the last thing I want my patient with a stroke or a heart attack to do is start shopping around and looking at which would be the cheapest place to get their emergent procedure done. I want them to show up as close as possible, as quickly as possible. So I do worry that if we marry this with high deductible health plans, as has been done in the past, that we're not going to solve the problem.
Price transparency doesn't solve the problem of high deductible insurance plans, and it doesn't solve the problem of people who are in a crisis situation and are, so it is not a solution to all problems. But I do think in the short term, it is a way of trying to get some accountability in a system where, I mean, even sometimes within the same institution, you might have very different prices for the exact same procedure, just depending on whether you have what insurance you have or whether you're paying cash, which might actually be the cheapest way of paying for your procedure. I'm out of time. Thank you. Thank you, Chair Sanders.
Senator Murphy.
Thank you very much, Senator Sanders. Thank you so much for having this hearing, and thank you all for being here. Senator Cassidy, thanks for helping put this together as well. This is an issue that I've worked on for almost 2 decades. I led Connecticut's first effort to put in place pro-consumer debt collection practices when I was a state legislator, the chair of the Public Health Committee, and I'm excited to have introduced a bipartisan piece of legislation with Senator Braun, the Strengthening Consumer Protections and Medical Debt Transparency Act, that would make a number of incremental but important reforms to the current system. One of the things we've seen in Connecticut, for instance, is that Sunlight often shames providers who have extraordinarily high rates of, for instance, referring claims to debt collection agencies well outside of the state mean into better practices. When we undertook our state reform effort, Yale New Haven was an outlier in the state, being much more aggressive than other hospitals in collecting debt. Today, they are frankly one of the most consumer-friendly hospitals, in part because of Sunlight. Danbury Hospital was at the top of the list, and then an effort to show that Danbury's practices were well outside of the mean helped them bring them back into line as well. So that works in Connecticut, but it works in Connecticut largely because we have not-for-profit healthcare hospitals that have a community board, have a responsibility to the community. Increasingly, though, hospitals and healthcare practices are owned by private equity firms, are owned by shadowy, unaccountable financial organizations whose only interest is in driving profit, in driving return for investors, and have no connection to the on-the-ground practices that impact consumers. Dr. Messac, I think you talked about this in your book, the impact that the extraordinary increase in private equity ownership of doctors' practices and hospitals have on debt collection. I want to ask one additional question, so give me a minute on what you found.
Yeah, thank you, Senator, and thank you for your leadership on this issue. You really have been at the forefront. A lot of us, 3/4 of us now, physicians, work for large corporate entities, and that includes nonprofits, but as well private equity companies, insurance companies, and it takes a tremendous toll on patients. There is not that connection to the patient, as you said. There is not that history of a relationship to the community. And as a result, a lot of the most recent cases of a very aggressive debt collection, filling up courtrooms, oftentimes in the American South, are taken by private equity companies. And so those are the entities that really have taken the lead in aggressive pursuit of low-income patients.
Yeah, again, these are ownership companies that are only interested in a return on investment. Now, that's extraordinary that we have allowed that to become the norm in our healthcare system. We aren't too far from an era in which we thought healthcare was so important, kind of like elementary schools, that there should be some connection to the common good, and now that is vanishing. Dr. El-Sayed, I wanted to ask you about medical credit cards, which is an extraordinary new phenomenon driven in part by the financialization of our healthcare system. Hospitals are adopting these cards. In one North Carolina hospital, they went from 9% of their patients paying interest on their bills to 46% of their patients paying interest on bills because the hospital brought in a credit card company. And instead of just putting patients on installment plans, they now sent them to a credit card company. These credit card companies are charging extraordinary interest rates, are often overhyping the benefits of the card. Do you see this as a problem for your patients?
I think it's a huge problem. And to your point, you could imagine a world where the same private equity firm owns the credit card and owns the hospital that provides the care, right? And you think about conflicts of interest, and it's profound. The other side of this is that we talked about some of the benefits of, or some of the unique aspects of medical debt and the ways that policy has sought to pull them out of the traditional consumer monitoring. When you talk about credit card debt, which is what you're doing, is transferring debt owed to a hospital or a clinician to a credit card with super high APR, now you start to appreciate the fact that they don't benefit from a lot of that. And so this is an extremely pernicious, new way of trying to further financialize the cost of getting exorbitantly high-priced healthcare in this country.
Finally, quickly, Dr. Chino, I saw you nodding your head. It seemed in skepticism of transparency, price transparency is the only means to solve this problem. I share that skepticism, so just a few seconds on why you were nodding your head.
Yes, we've done some fair amount of research on price transparency, and we found that price transparency is, number one, not adhered to. Our evaluation of NCI-designated cancer centers found that less than a quarter were adherent. But of the prices that were posted, they were huge variation. So for a single service, one hospital was charging $300, another one was charging $30,000 for the same service. These are all at NCI-designated cancer centers. So when you think about that level of variability, that is the free market. That is, you get as high a price as you can get, and that is not the way to run healthcare, to maximize profit.
Great. Thank you, Mr. Chair.
Senator Braun.
Here we are again on a very familiar topic. I just left the Aging Committee, and it was about healthcare transparency. All the gimmicks insurance companies and hospitals employ in a market that lacks it completely. And even becomes a bigger issue, of course, the older you get, because you're going to engage the healthcare system even more. I think it does operate almost like an unregulated utility. I've said it so many times, I almost feel like I'm getting blue in the face saying it, but the industry has never had to comply with any of the normal features that make a market out of something, which is full transparency, an engaged consumer, no barriers to entry, and yes, price transparency. Every other industry deals with it. We don't have it here. Senator Sanders and I have introduced a bill that tries to be as global as it can get to put this into play. I know it can work, wrestled with it in my own business. There was nothing on your P&L that was harder to control than healthcare. And this was back in 2008, and the company was 1/5 the size it is now. And if I had not tackled it in an entrepreneurial way to, number one, engage the healthcare consumer. For those that can afford it, they need to be out there shopping around, dealing with you like you would if you'd buy a big screen TV. I know many people would travel 50 miles to save $50 on a $1,000 item. Well, we don't have any of that dynamic. And it's sad on what is the largest part of our GDP that we got to wrestle with it like we do. The reason we have medical debt is because it costs too much in the first place. And until we reform the industry, and in any other kind of industry that's a monopoly or an oligopoly, it's called a utility. And utilities get regulated. If the industry doesn't wake up, that's exactly what's going to happen. Sadly, that's kind of where it's gone in almost all other countries. That gets the cost of healthcare down to closer to 10 to 12% of our GDP. I'd like to ask Dr. Bai about what would happen if healthcare was in that realm of full competition, transparency. Can we fix it, or is it too far gone to where you'd have to do what many other countries have done? You know, it's a one-payer system, because that's what happens. That's what a utility is. You sooner or later are going to get regulated by government. Are we too far gone, or can the system still be fixed?
No, we are not.
Tell me why we can get this bill passed and maybe start cracking the industry to where it's performing like most other segments of our economy.
The Braun Senate bill is an amazing bill. The details in that bill ensures price transparency and promote competition, and more importantly, in the short run, can make sure medical debt and the medical billing integrity is preserved. So in the short run, we know the numbers are right on the medical debt. In the long run, think about the three things. Number one, patients, right? Patients who have more control of their medical care dollars, and they can shop around, can benefit personally directly from lower price and higher health, not higher health insurance, but higher health status. But then the employers will get all the freedom, get a flexible design of their benefits. So they can just have more freedom to fund or purchase healthcare for their employees. And number three, more importantly, the physicians will get all the freedom to innovate and deliver care. So we have all the innovation for both care delivery, for innovation in medical care, as well as in how we design the benefit. So eventually, this system will work because it relies on two important forces. Number one, on the buy side, people want the cheaper and better things, including healthcare. Then on the sell side, all the innovators and providers, physicians, want to make money. But in this process, they innovate and get the best things for consumers.
Well, thank you. And before my time runs out, to me, this would be the most transformational bill that I've seen since I've been here. And I know how hard I worked on it to fix it in my own company. It can be done. Sooner or later, the industry is going to have to wake up and get with it. I want to say, shout out who else is on it. Bipartisan quickly. Senator Smith, Senator Hickenlooper, Senator Grassley, Senator Coons, Senator Hassan, Senator Ernst, Senator Baldwin, Senator Warren, Senator Fetterman. Every senator in this U.S. Senate ought to be for taking the biggest sector of our economy and turning it into something that's going to be responsive to healthcare consumers. Thank you, Chairman Sanders.
Thank you, Senator Braun. Senator Casey.
Mr. Chairman, thanks very much for having this hearing, you and the ranking member. I wanted to direct I'll just have one question for Ms. Ward. I appreciate the testimony of everyone, and sorry we were juggling, as I'm sure Senator Braun might have shared. We're juggling hearings today with the Aging Committee and the Help Committee. But Ms. Ward, thank you so much for sharing your family's personal story, and I'm happy to hear that your sons are now thriving. And as you know, our nation has a fundamental, sacred obligation for children who need care. And unfortunately, that sacred obligation has not been met time after time. For almost 60 years, Medicaid has been our way of fulfilling that obligation. This program is a lifeline for millions of American families who use it to access care for their children, particularly in rural areas. The utilization of Medicaid and CHIP, Children's Health Insurance Program, is higher in rural areas than it is in urban areas because of the folks' incomes in those communities. I've introduced a bill to automatically enroll every child in the country, every child, in Medicaid at birth. And they'd retain that eligibility to the age of 18 without the need to re-enroll annually. The bill would guarantee coverage for over 2.6 million children in Pennsylvania. It would mean that no child will ever again be forced to grow up struggling to stay healthy due to lack of health care coverage. Medicaid includes, as everyone knows, the so-called EPSDT, Early Periodic Screening, Diagnosis, and Treatment benefit. It's one of the best features of Medicaid, and we don't talk about it enough. This means that for children like yours with ongoing health needs, Medicaid would cover everything they need to identify and treat a health condition to ensure the child can thrive. So, Ms. Ward, I'd ask you, you mentioned that your family did not qualify for Medicaid and that you worked extra hours to pay for their physical, occupational, speech, and feeding therapy. Would Medicaid coverage for your twins, including the benefit of EPSDT, have helped limit your financial burden?
Thank you for the question, and thank you for your important work on this issue. My answer is yes, absolutely. It would have improved their outcomes.
And do you have any advice for us on how to make the case for the need for this legislation?
I think one way is to look at the outcomes of children who have appropriately received care and look at how their lives and their quality of life is much different than those who do not, and how their lifetime what's attained in their lifetime looks very different than children who do not receive the appropriate developmental interventions.
Well, I think the story that you've told and other families have told and have experienced is one of the ways to make the case for this legislation. Medicaid is a godsend for so many families. We've got to protect it. We've got to strengthen it. I think we should expand it in the fashion that I just outlined, including, or I should say in addition to what we did with Medicaid expansion in 2010. Mr. Chairman, thank you, and that's all the questions I have.
Thank you very much, Senator Hickenlooper.
Thank you, Mr. Chair. And you covered this a little bit in terms of the cost, the lab fees and diagnostic tests that are leading drivers of the accumulation of this debt. I think that the Healthcare Price Transparency Act put forward by Chairman Sanders and Senator Braun, we're a co-sponsor, but the Healthcare Price Transparency Act really does require all negotiated rates and cash prices to be published for all shoppable healthcare services. And I guess I'll start with Dr. El-Sayed. How do you think transparency measures in this bill help, what role can that play in actually addressing the cause of the creation of debt?
I really appreciate the question. I think that it plays an important role. And I shared my own story about needing a surgery for an inguinal hernia, and that's the kind of shoppable healthcare that applies to. I do think that we need to be thinking about it in comprehensive inclusion with care for the kind of healthcare that a lot of folks, or payment for the kind of healthcare that Dr. Messac takes care of, which is not shoppable and has to be done at the edge of real risk. And so it is definitely part of the solution, and I think can be included in a broader package of asking how do we provide support and care for all the needs that people have.
Right, I agree. Dr. Bai, you mentioned in your testimony that the increasing competition in the marketplace is one of the most impactful aspects of lowering costs for patients, and certainly I couldn't agree more. Competition, appropriate competition, has historically always allowed us to lower costs, but it has to be tied in with a level of transparency. And I think that kind of competition can push healthcare providers to continually innovate, which I think if you connect that to the increased transparency to patients could be a catalyst for finally lowering prices. So what can we do at the federal level, not only to prioritize the policies that promote competition in the marketplace, but making sure that those savings, make sure that those savings ultimately reach patients?
I think number one is to let the patients, let the individuals control their dollar for healthcare. Right now we're detaching. Let's say I'm a Medicaid patient. If I work out every day, eat healthy, I become healthier. That cannot benefit at all, right? And then if I want to see a different doctor, I can't. So these kind of regulatory constraints make sure that the patients cannot personally and directly benefit from better health or lower price. So we have to fix that. And number two, we must level the playing field. Right now, we totally, Congress and the government totally tilted the playing field in favor of big players. Then guess what? If I'm a big player, if my money comes from the government, I'll just focus on influencing the process. I do not care about patients, right? Because they don't bring money to me. But if you have a competitive market, guess what? My money comes from patients. I must make them happy in order to be rich. We want to be rich, but how do we do that, right? We must make patients happy, not the government happy. I think that's the key.
Right. I appreciate that. That's a thoroughly American capitalistic approach.
I came from China. I like American dynamism.
Colorado, we feel a certain amount of pride to help protect consumers from the harms caused by medical debt. And last year, we were one of the first states, I think we maybe were the first state in the nation to enact a law that prohibits the inclusion of medical debt on credit reports. Another law in Colorado caps the allowable interest on medical debt at 3%. It goes from 8% down to 3%. Dr. Messac, in your testimony, you discussed the sad frequency with which patients forego necessary medical care out of fear for the bills that they're going to face afterwards. How does making changes in credit reporting and capping allowable interest lessen this burden on patients so that they can focus on getting the care that they need?
Thank you, Senator. I think those are two huge steps. We know that patients who received, who had their credit reports, medical debt removed from their credit reports in recent studies did see an increase in credit access. We know that patients are worried about what's going to happen to them if they don't pay their debts, and they have reason to fear those bills. And so if we can relieve them of some of those fears of ending up in a courtroom paying off not only their medical bills but also court costs and interest charges, as you mentioned, that'll be a huge step towards making sure that patients can follow through on treatment recommendations and get the care that we want them to.
Great. I couldn't agree more. And I think that the patient's optimism and comfort, pretty much every doctor agrees that that is part of therapy. And having the debt and this accumulation of debt, the fear and anxiety that creates, cannot be healthy. I yield back to the chair.
We are waiting for another senator. In the meantime, I think Senator Cassidy and I had a few questions we'd like to ask. This has been a very interesting hearing, and I think everybody, regardless of where you're coming from, understands that the root cause of the crisis of medical debt is the high cost of health care in America. And the interesting discussion is to why we are spending twice as much per capita on health care as any other nation, and our outcomes are often not as good. I would mention to folks there was a study recently at the Peterson Foundation which talked about administrative costs. Now, I would hope that most of us agree that if we spend $1 on health care, we want it to go to a doctor or a nurse or some medicine. We don't want to go to some bureaucrat hounding or some bill collector hounding Ms. Ward or Dr. Chino, who's worried about family members. Not a very good investment in healthcare dollars. Just for the record, in Japan, they spend about $70 a year per person on administrative costs. Sweden, $70, Italy, $74, Australia, $148, France, $306, Switzerland, expensive, $528. In the United States, we spend $925 per person, not on doctors, nurses, but on bureaucracy. All right? Brief answer. Now, I'm going to give you my view. You tell me what you think about it. And this really raises an interesting question with Senator Cassidy. We may want to do another hearing, really. I think that the function of a rational, humane healthcare system is to guarantee healthcare to all people, regardless of income, as a human right. I think it's wrong if somebody says to Bill Cassidy here, Bill, sorry, you have cancer. Too bad you're going to die because you can't afford the treatment. I don't think that that's what a civilized society should have. That is what exists right now. Dr. Sayed, now go right down the line to everybody. What should be the function of a sane, humane, cost-effective healthcare system? Doctor?
I'd say It's to prevent the illnesses that can be prevented, treat the illnesses that can be treated, and to prevent the adverse consequences of getting sick in the first place.
Dr. Messac?
To look out for patients, that's the oath I take, and that should be the function of our healthcare system.
Regardless of income.
Amen. Yes, absolutely.
Ms. Ward?
To help all families and children thrive in any way that they can, the best way that they can.
Dr. Chino?
I think our health insurance system, our health care system should invest in the American people, because when you invest in the American people, it will always pay out for you.
Dr. Bai?
I believe we should make all the stakeholders able to benefit themselves. Then eventually that will benefit society as a whole. Everybody wants to be rich. Through competition, then people innovate and eventually drag down price and improve quality, benefiting all Americans.
Dr. Ippolito?
I think the goal should be to balance cost and the innovation that generates lots of health that we enjoy.
I just read statistics. I think there is no denying, or somebody can deny it if you want, that our system is not only the most expensive, it is the most complicated, the most bureaucratic. Everybody in America spends half their lives filling out forms, arguing with insurance companies, all of which cost an enormous amount of money. Dr. El-Sayed, what is the solution for creating a simple, cost-effective healthcare system?
We've heard a lot about providers and payers, and it's important for us to differentiate between those two. Healthcare providers are the doctors, the hospitals, the folks you see to get care. That should stay private. It encourages competition, and competition is good. But there is no innovation. There is no improvement on the insurance side. This is an industry that sits as a middleman between individuals.
What is the function of the insurance industry?
In theory, they're supposed to protect you from the financial consequences of getting sick.
In
reality, it's to make a lot of money for CEOs of large health insurance corporations.
Dr. Messac?
I agree. We have to cut out the middlemen in healthcare. There's way too much money floating around between patients and the healthcare providers that's never benefiting patients at all.
Why is it, anybody jump in, that we are spending less than half as much per capita on primary health care than virtually every other major country, where I think we all understand the function of a good healthcare system is to keep people healthy? What role do the insurance companies? Do the insurance companies make any money by keeping you healthy? Dr. Chino?
No, sir, they do not.
Dr. El-Sayed?
Yeah, I'll say as a public health official, this is a place of mass frustration because in theory we should, but we've made Medicare the insurer of last resort rather than the insurer that should cover you your whole life. And so what happens is any investment that they make in prevention early on is going to redound to Medicare's benefit. So there's really no incentive for them to invest upfront in keeping you healthy, but rather we have a situation where they're being subsidized over the long term, and so that prevention's not happening.
Senator Hassan?
Thank you, and thank you to you, Mr. Chair, for the hearing, and Ranking Member, thank you for the hearing, and thank you for your courtesy just now. Thank you to our witnesses for being here today. I really just have two questions, and I want to start with Dr. Ippolito. One of the many factors driving healthcare costs and medical debt is unfair fees for routine care, even for Americans who have health insurance. For example, I've heard from Granite Staters who've been charged hundreds of thousands of dollars for a regular doctor's visit just because, hundreds or thousands of dollars for a regular doctor's visit just because their doctor's office has been purchased by a hospital. Dr. Ippolito, can you talk about some of the root causes that are driving these higher healthcare costs and unfair billing practices?
Well, I'll stick with the example that you started with. One of the big challenges that we face right now is consolidation on the provider side, on the insurer side, throughout the system. You bring up a great example where we have a number of policies on the books that encourage lots of consolidation in the provider side. And what that allows people to do is both take advantage of rules in Medicare to charge higher prices and in the commercial market charge higher prices to anybody who walks through the door. So the combination of those two things clearly contributes to high health costs, and it surely contributes to medical debt.
And what are your suggestions about ways to curb these trends so we can protect patients from these unfair facility fees?
I mean, on this side specifically, site-neutral payment seems like number one.
Okay, thank you. Dr. Messac, I wanted just to touch with you on something you discuss in your testimony. Many of your patients that come into the emergency room, you say, are fearful of incurring medical debt. Can you speak to the impact of medical debt on a patient's decision to seek care, particularly early care?
Absolutely. I mentioned in my testimony about a patient with late-stage cancer who could have been treated early if she had showed up but feared for the costs. I also want to mention patients who come to the ED and we find that they are at risk for very serious conditions, heart attack, stroke, but we don't have that diagnosis yet. And we need them to stay for more testing, just overnight, just for more testing. This conversation comes up all the time. And they always ask, how much is it going to cost? I don't know the answer, but it'll cost them something. And oftentimes they don't stay. And we don't get that diagnosis that could save their lives.
I appreciate that. That's all I have. Thank you, Mr. Chair and Ranking Member Cassidy.
Senator Cassidy.
Yeah, thank you. I just want to comment on some things and then I'll ask some questions. Going to that patient again, by golly, Brigham is a 340B disproportionate share nonprofit hospital. There should be some allowance for someone, and Massachusetts is a Medicaid for expansion state. We've got programs out there. Dr. Chino, you were a little bit like one hospital is $300 and another's $30,000. Price transparency doesn't work. That's how it does work. I'm going to go to the hospital that's $300. If I'm the employer, I'm going to find the deal which is cheaper. And so that's actually how price transparency is supposed to work. It's not a flaw. It is kind of how it was designed. I also want to point out for the patient coming to the emergency room, one of my doctors down here at the left, my left, spoke of, well, you're in a coma, how do you know? But the No Surprises Act says that if you go to any emergency room with an emergency, that's going to be treated as an in-network expense. So Congress is attempting to address that. We can't just do something, we actually have to think. Dr. Bai, I just looked up a paper, and I'm not sure I got the paper that Dr. Messac referred to, but a meta-analysis of the impact of high deductibles, because that's been kind of the conversation here. And it pointed out that the health outcomes are the same between high deductibles, low deductibles, and a couple other things. But initiation and continuation of medical therapy is lower in those with high deductible. I go back to 340B. If hospitals were passing on the 340B price to the patient who is financially stressed, then a policy initiative by Congress would actually be making a difference. But it's not being implemented.
Right now, there's no requirement that 340B hospitals have to pass on the savings to patients. That's why
if we had such a requirement, then in this meta-analysis, we would address the only finding that was found as a true negative, that patients are unlikely to initiate, or less likely to initiate and continue.
That's correct. That will directly help patients.
And there was a statement earlier implying that somehow not-for-profit hospitals are better at this than the private equity. I'll point out that every bad incident we've talked about today has been a non-for-profit hospital not passing on savings from 340B or fulfilling the obligation that they receive for being a tax-exempt facility and, in some cases, a disproportionate share hospital. I'm not sure it's a failure of public policy, it's a failure of the implementation of public policy.
If I may also add, there's billions of dollars in tax exemption value. Remember, nonprofit hospitals don't pay tax, but also they receive tax-deductible contributions. They receive a lower cost of borrowing because of the interest tax.
So as a 501c3, both the contribution they receive and the capital gains upon their corpus are also tax-free.
That's correct, yeah. So there's not just tax value itself, but there's also other derivative values.
So let me ask you also, because you mentioned in your testimony the role of health savings accounts that can both preserve the ability or the incentive for someone to be a shopper for her own financial health as well as her physical health, but also protect her from having a large out-of-pocket. Can you briefly comment on that?
Absolutely. We need to unleash the potential of HSA, health savings account. And you have a bill, Senator Cassidy, to allow HSAs to cover primary care and direct primary care. That is great, but I think we should go beyond that. Let us say HSA cover more and more non-major but routine services. Remember, insurance is supposed to only cover major events, right? That's why we don't have oil change. We don't have wiper replacement covered by car insurance. Otherwise, insurance premium will be very expensive and being marketed out of the market. But then because of government regulation, right now we have insurance covers everything and does not allow patients to benefit.
Dr. Ippolito, your testimony is very interesting, that somehow the credit score of patients, even though it's no longer counted against them, but the overall financial health of somebody, even if you subtract out the medical debt, often does not change. Can you comment on that, please, very briefly?
Yeah, sure. So one of the things that you observe is that people who tend to have medical debt also have other delinquencies on their credit reports, and it is also the case that medical debts often are not paid once they have been sent to collections. And so at that point, whether you get rid of that debt or not, and we've studied this across Medicaid, Medicare, ACA, literally randomized controlled trials of eliminating debt, and you see the same result over and over again.
Purchasing the medical debt and forgiving it may relieve somebody of dunning phone calls, which are awful, but on the other hand, it may not actually change the balance sheet.
Yeah, the average effect is going to be very small on the balance sheet.
Very small, even smaller than the 10% that's being paid or the 1% that's being paid. Presumably the collection agency gets their share too.
Yeah, the reason the price is so low is because the reimbursement is so low. Very few get paid.
Thank you. Thank you all.
Well, let me thank all of our panelists. I thought this is a very interesting and informative hearing, and it really touches on the fundamental debate that we're having, I think, as a nation. Is healthcare a human right available to all people? Or should we look at healthcare as an opportunity for large insurance companies and drug companies to make tens and tens of billions of dollars? And that's a debate that we have not resolved at this hearing. We're going to take it forward. But I do want to thank all of the panelists for their testimony. This is the end of our hearing today. For any senators who wish to ask additional questions for the record will be due in 10 business days, July 25th by 5 p.m. I ask unanimous consent to enter into the record one statement in support of addressing the medical debt crisis in America. The committee stands adjourned.